right, we're right at noon. Thank you everyone for joining us. We will begin in just a moment. We will have the chat and the Q&A box open for any questions that you may have. We will have a Q&A session at the end if there is time. So feel free to send those questions to the chat or the Q&A. I'm going to turn it over to Dr. Vora, who will be starting our session today.
Thank you, Amanda. Welcome to everybody to our latest Rural Health Summit webinar, COVID-19 and Rural Public Health Systems. On behalf of Southern Illinois University School of Medicine's Department of Population Science and Policy, the SIU Paul Simon Public Policy Institute, the University of Illinois at Chicago School of Public Health, the SIU Center for Rural Health and Social Service Development, it is my pleasure to moderate today's webinar. My name is Samir Vora. I am a general pediatrician and the founding chair of SIU's Department of Population Science and Policy. And today we have an incredible group of leaders across the state of Illinois that are working on issues that are directly impacting the health of our rural communities. These are public health leaders and a healthcare leader to tell you about some of the challenges and innovations that are happening in our rural public health systems and how we can think about building brighter futures for our rural communities as we get to the latest stage of our COVID-19 pandemic. So as Amanda briefly said, this is our third webinar in our Rural Health webinar series. And this third webinar, we started the webinar series actually in April of this year and worked on and talked about issues of our aging population. Our webinar in May talked about mental health. We took a little bit of a break in June to have the SIU-SIH, Southern Illinois University, Southern Illinois Healthcare Health Policy Institute, but we're back this month talking about public health systems. This is the third of 9 webinars that we'll have all the way through January 2022. And so please see this link, and we'll also share it in the chat for ways that you can sign up for these webinars moving forward. And we'll sort of have an announcement on our next webinar around nutrition and fitness coming up at the end of this webinar series. So let me get straight to it and begin announcing and telling you a little bit about the presenters that we have and the panelists that we have today. As you can see, that there are 4 real leaders across the state of Illinois doing positive and unique things as they work on the health of rural communities. So first, I will start with Dr. Amal Tokars. She serves as the Assistant Director at the Illinois Department of Public Health. Dr. Tokars has a Master of Science in System Therapies in the clinical setting, and her doctoral work emphasized her love of organizational learning, social movement, and research methods. Her work experience includes over 30 years in behavioral health and approximately 15 years in the public health arena, as well as having experiences in clinical, policy, and research. Her areas of particular passion include cultural equity, health ethics, system change, international policy, and engaging in dialogue about the essentialities of a thriving civil society. Dr. Tokars, thanks so much for joining us.
Thank you for having me.
Next is Jeffrey Erdman. Mr. Erdman serves as the Associate Executive Director for the Illinois Public Health Association. Mr. Erdman has 25 years of experience in the public health programming field, including decades of experience implementing programs in social determinants of health, health equity, HIV, AIDS, and sexually transmitted infections, and revenue generation programming for local health departments, community-based organizations, and other healthcare providers. Mr. Erdman also is a nationally recognized public health programs evaluator, administrator, and capacity building provider, and has been honored with awards from the Illinois Department of Public Health, the American Association for World Health, and the Society of Professional Journalists. Mr. Erdman, thanks so much for joining us.
Thank you for having me. Happy to be here.
Our third panelist is Ted Rogalski, who is the administrator for Genesis Medical Center in Aledo, Illinois, a 22-bed critical access hospital. Mr. Rogalski completed his bachelor's in business administration at St. Ambrose University and received his master's degree in healthcare administration from the University of Iowa. He is a fellow in the American College of Healthcare Executives. During his 23 years with Genesis Health System, Mr. Rogalski has held a number of leadership positions, including directing operations in Aledo for the past 10 years. He also serves as chair-elect for the Illinois Hospital Association Board of Trustees and serves as the treasurer for the Illinois Critical Access Hospital Network. Mr. Rogalski, thanks so much for joining us.
Thanks for having me, Samir. I'm glad to be the outsider joining this group of public health leaders.
Well, we're very happy to have you. And our fourth panelist is Miss Jennifer Hammerlink, who is a registered nurse with 35 years of experience in home health care and public health with a focus on quality improvement. She is the supervisor of health promotion for Mercer County Health Department and the project director for the Health Resources and Service Administration Rural Health Outreach Grant Mental Health Action Program. She has 20 years of experience in grant writing and implementation and management of grant projects at the state and local levels, and has secured over $3 million in grant funds for Mercer County and Mercer County Health Department. She also has extensive experience in community needs assessments, coalition building, and strategic planning. We are so excited to have you, Ms. Hammerlink, and excited for this really engaging conversation over the next hour.
Thank you for inviting me.
So before we dive deep into the conversation, we wanted to remind everybody how we got here. And so part of the hope of this webinar series is really to understand the challenges of the COVID-19 pandemic across our communities. And so the Rural Health Summit Planning Committee, which consisted of the partners that we mentioned at the opening of this webinar, convened stakeholders from 55 different organizations for 11 discussion forums during the summer and fall of 2020 to better understand and address the COVID-19 pandemic in rural Illinois. We discussed those 9 topic areas and really tried to understand how those areas were being affected by the pandemic and what lessons that we could learn to really create recommendations for future action that could foster healthier communities. The discussion forum participants were then invited to an additional session at the end to sort of identify common challenges across those 9 topic areas and synthesize impactful solutions. And the information, anecdotes, and issues raised became the basis of a series of reports and these conversations that we're having in 2021. So our first report launched in March 2021 called Building a Healthier Rural Illinois, Understanding and Addressing the Challenges of COVID-19. That outlined sort of the bigger and deeper challenges of our rural communities, identifying them with, as we had called them, the 5 Ds. That rural communities start at a disadvantage, first D, due to experiencing food, healthcare, social service, and data deserts, D number 2, as well as organizational and technological disconnection, D number 3, often with the way that organizations worked in silos. And as we found out so much during the COVID-19 pandemic that the need for high-speed internet became an essential need for so many of us during the pandemic. That rural regions do experience similar disparities, D number 4, to low-income urban areas, but often have fewer, D number 5, developmental opportunities than their urban counterparts. We then synthesized a series of recommendations in our original report to think about how we could go across sectors to make an impact. And then starting in April, issued specific topic-focused briefs that were then followed by those webinars. Aging rural population in April, rural mental health in May, and today's topic of rural public health systems in July. And so we'll focus the rest of our conversation now here. So we'll move out of the PowerPoint and kind of move just to the bigger discussion. And Assistant Director Tokars, I'd love to start with you and to give us and the audience here just a sense of the incredible weight that has been put on our public health department to tackle a pandemic, one of a kind, the first that we've seen like this in 100 years, and the ways that the public health department has had to morph and change to think about the pandemic while also acknowledging all of the other public health needs that the state of Illinois and the public health department routinely has to deal with.
Well, I'll try to answer that succinctly, but I want to start by saying, Dr. Voha, that the position that the state health department has been in is the same that our local departments, health departments have all had to be in, with maybe just a very large magnitude of that, problems that would develop day to day aside from the pandemic, but related to it that there were no answers for, that we all had to, think of ways forward. But in this question that you're asking me, what are some of the things that we did maybe during that time, or what are some of our ways forward? And there are probably 100 things that I could say, but one thing that I want to say, first from the perspective of the state health department, and then my own as a public health professional, these will be very different answers. So for the public health department, one thing that we tried to do was, even though we were unbelievably immersed in the pandemic, maybe I myself would do 12 hours a day related to COVID, but then I still had many other things as our local health departments did that they had to do. So we as a department tried to also stay true to standards of operating that we wanted to exemplify for ourselves and others. So we continued with our health planning. We continued with our strategic planning. We continued with our program reporting. And it was important for us to be able to say that we could also pay attention to these things so that we wouldn't let them fall apart, because these all ultimately serve the people of Illinois. So I want to point out that for the state health department, and Dr. Voha, I think that I'm quite sure you were involved with this in our strategic planning. We did finish that strategic plan, and we are currently, even though we're swamped, implementing that, which involves, and it was informed by the pandemic, absolutely. So that involves us looking at health disparity and health equity, looking at our own internal ability to gather data, which is always a challenge for everyone, looking at our internal collaboration, looking at our internal resilience. And again, this is a strategic plan, not the health plan. looking at our communication, and looking at the importance of our workforce and our future workforce. But I want to mention for myself, one of the things that really has highlighted my thinking during this pandemic, and this is going to sound very abstract, that we often think of ourselves personally and as professionals looking to the end when all will come back to the way that we were. And what I have said to myself and to those that work closely with me, let us not burden ourselves with the expectation that we will ever again be the way that we were. Instead, let us continue to grow and develop and be better. And, you know, for some people, letting go of the way that we were feels bleak, but it also can feel very freeing to not have to replicate the hardship and the limitations, and to really just think about what we are doing now and what we can do going forward. So that is, for myself as a professional, something that has been very much informed by the pandemic. And I want to let you go forward with our other good colleagues here.
Thank you, Assistant Director Tokars, for sort of setting that stage for us and describing, I think, what, you know, we would love to kind of get into deeper, you know, with the rest of the panelists too. But before we get there, Mr. Erdman and Ms. Hammerlink, you know, I'd love for you to sort of, with the audience that we have here, you know, across a whole bunch of, you know, different sectors of society. And Mr. Erdman, I'll sort of start with you. Of what was the position that our rural public health departments, especially, what was the foundation that they were facing before the pandemic? And a little bit sort of into the eyes of, you know, when they saw this hurricane, if you will, the pandemic coming, you know, things that, how were they set up appropriately? And I think we'd love to sort of use Mercer County, Ms. Hammerlink, after Mr. Erdman goes, to sort of set the example of what you guys faced in your own county health department.
That's a really great question. Thanks for asking it. I think our health departments were really challenged before the pandemic. There was a report that just came out recently that said the public health workforce across the country is 250,000 public health workers short of where we need to be. That's a devastating lack of public health workers that we face. And that is true across Illinois. Our local health departments, they are incredible organizations, and they have incredibly passionate workers and did an amazing job in the COVID pandemic. But before the pandemic, they were understaffed. We have a local health protection grant in Illinois that funds our local health departments. That funding should be about $30 million. We're currently at about $19 million. So we are significantly short of where we need to be for local health protection funding. That funding funds, you know, the basic needs of the health department to inspect, you know, environmental health, to do our WIC programs, to do our immunizations, to do our basic services. So we were underfunded before the pandemic even started, and we had a lack of staffing to the tune of 250,000 less across the country. The other thing to think about is in our most rural health departments, so we base our local health protection funding on a per capita basis. Some of those rural health departments were getting less than $1 in per capita funding for their local health protection grant. So they didn't even have the basic resources to fund their ongoing projects before the pandemic hit. Some health departments, Southern 7 is a great example. They cover 7 counties in the southernmost part of the state. That's the size of the state of Delaware. And so they have to cover 7 counties with an understaffed and underfunded resource. So I think it's a great question, but our public health system was woefully underfunded before the eye of the hurricane sort of hit us.
Would you like me to expand on that?
Please, I'd love for you to.
Okay, I completely agree with that statement. A lot of the things that we came up with as a team in preparation for this panel had to do with funding. I think that the shortfalls that we already knew that we had, the spotlight just shone so brightly on those when the pandemic hit. And a quality skilled workforce is a terrible gap in service here. Our health department has whittled down to, we just laughed, for a few years, we're just a skeleton crew. We're all wearing multiple hats. We have a low tax levy. We have state funding that continues to decrease in key areas like WIC and family case management. And so it didn't allow us to build the robust workforce that we needed during the pandemic. We grew from a staff of 13 to 36 during the pandemic. That's how many temporary workers we had to hire to just get us through COVID, because as we've referenced, many of those systems are still in place. We're still trying to be a great public health department, not just respond to COVID. And so that challenge and others such as emergency communication systems in the rural area, we don't have reverse 911 or consistent broad mass messaging system in the county. How emergency housing, as people struggled during the pandemic, fell to us. We have little to no emergency housing in the county. Resource management remotely was also quite a challenge as we asked staff members to stay home. And just vaccination sites, I think sometimes there's a misperception. In the rural community, it's hard to find those kind of facilities that are good during all weathers and are able to be staffed by the small crew that we have. And so I'm very proud of the work that Mercer County did, and definitely the partnership with our local hospital was critical. But going forward, we really have to look about how we keep a qualified workforce and we keep resources funded in the rural health department. So if something happens again, we're not just scrambling to survive all the time.
Yeah, and Ms. Hammerlink, we'd love, just to give us and give everybody on this webinar a little bit of a foundation.
Sure.
I'd maybe ask two sort of follow-ups. Tell us a little bit more about just Mercer County in general, so the people
Sure.
that don't know it. And I think one of the other things that often for those that aren't, fully vested in or have visited a public health department, just a list of some of the services that you guys provide for the individuals in the county.
Sure. I mean, we do WIC and family case management, the immunization program, breastfeeding peer support, the Office of Emergency Management, which encompasses public health emergency preparedness and the county emergency management. One person wears both of those hats. We have a large mental health program. We do tobacco prevention, lots of promotion type grants like women's wellness, Heart Smart for teens. There's just an emergency food pantry. We're putting in a washer and dryer. We're kind of, us in the hospital, we're the hub where people turn to for almost every one of their needs, whether it be healthcare or community resources. We're a small county, about 15,600 people. We're considered rural, low income, lots of agriculture and industrial. Our geographic area is so large that our local school district is the 5th largest geographic area in the state of Illinois. And so we don't have much of a public transportation system, just a limited part-time van that people can try and use for appointments. So there's a lot of challenges to the residents.
Yeah, thank you so much. And I think part of the importance of when we think about rural communities, just the challenges around geography, and sometimes, right, how we think about health. Mm-hmm. And traditionally, and I turn to Mr. Rogalski here, when we think about health, the first thing that we think about is the hospital, right? And often, and I know, and I love to get into this a little bit more detail a bit later about sometimes there isn't great partnership between, hospitals and the public health department. But I think, Mr. Rogalski, we'd love to kind of hear from you just from that aspect as an administrator, someone leading a hospital during COVID. What were some of those sort of unique things that you felt? And was the hospital, and I asked that question about the public health departments, was the hospital prepared for what they were facing with the pandemic?
None of us were prepared for this pandemic, that's for sure. But, as Jennifer alluded to in her comments, between our two organizations, we are the hub, right, of healthcare for our greater community. And we're truly blessed with an amazing relationship. And it goes back to the day I started. I think I've been in the organization for 10 years, and we have just enjoyed a very mutual, beneficial relationship where we collaborate on anything. And during the pandemic, that started from day one in our community. We stood up our community-wide emergency disaster group incident command center. And so leaders, across organizations, but it was really led by our director of our public health department and myself to guide those discussions and really prepare our community. Now, we were blessed, right, because we got to learn from the East Coast and kind of get things started. We're part of a health system, so we're part of Genesis Health System. So there was some benefit to that during the pandemic in that, our supplies was not a concern. So that allowed the health department to share supplies across the greater community and not worry about the hospital, right? So we do have a large county jail in our community. That was a key area to get them PPE. The other area where we collaborated very quickly was in our two nursing homes. We have two long-term care facilities, and I would say that they were woefully underprepared for this pandemic, but we brought them to the table and really coached them on infection control measures, making sure that they had enough PPE. So it was really taking that hands-on approach. And then, as we got through the pandemic, really focused together, the two of us, on vaccinations. And for a long time, we were leading one of the top rural communities in the state as far as getting our population vaccinated. So really, truly, we're blessed with that strong relationship.
And, and I think part of the hope, right, is just sort of to highlight some of those examples. And I think one of the things when we have been thinking about public health systems, just part of it is trying to get the communication around sort of complicated public health ideas to the public. And Assistant Director Tokars, I think we were all blessed in the state to have Director Ezike out and constantly talking about the importance of these issues. I'd love to get a sense from you, so how do we think, and you mentioned as an important part of the public health department strategy, so how do we determine how to communicate public health? Because I think to Ms. Hammerling's point too, right, public health does so much. And as we think about what comes into the future, I think there needs to be a better understanding of what public health departments do specifically. And then even overall, what do we mean when we talk about the public's health? And would love for you to kind of share your personal thoughts about it. But, I know this is being sort of so important for the Illinois Department of Public Health. How do we get people to better understand what public health actually means?
So I want to try to answer that question from the perspective of being the administrator in a rural public health area, because although I'm an immigrant to this country, most of my adult life, all of my adult life has been in a rural area, and I served until I came to the State Department in a rural area as public health administrator and also on school board as a school official. So I want to just mention, to add to some of the challenges that Jennifer's talked about and that Jeffrey and Ted have talked about, what I experienced, and I know many do. First of all, I have to say that it was clear to me that the abstract work of public health was not always supported locally, that more concrete things were more readily supported, like roads and buildings and things that were bringing in income. Public health is a service, is not intended to bring in income, and therefore it wasn't always supported locally. That being a backdrop makes it very difficult for a rural or any health department. That was one thing. Another is the fact that we did not have mass transit. Now, I know some rural areas have transit. Many or most do not. We did not. And mass transit, a lack of it creates disparity in job access. And that socioeconomic disparity that is caused there, we have to understand that every kind of well-being is inextricably tied to every other kind of well-being. So even though in public health we talk about comorbidities, well, there's a comorbidity, if you would say, to not having equitable access to jobs because of lack of transit. And even it causes access to healthcare issues. Just think about the vaccine clinics, people needing to get to dialysis, to the hospital. But I also want to add that we were a health department that if there was a fire and a building burned down, we would be turned to immediately to do all that we can. And I think that sounds similar to what Jennifer was saying. We just did everything that we could with whatever resources we could pull together. And so that, how do you communicate that? So here now is how I want to answer that question. The best kind of communication is when, yes, our director, Dr. Ezike, is talking about all these things, but also I found later in my career that it was so important for me to describe locally what we were doing, that I was brought up not to brag, not just to do, but I realized if we don't tell people what we're doing, they won't understand how important it is. So I think it's so important for local health administrators, it's not bragging, to describe truthfully the impact that you're making in your community. And I think that in combination with a very different kind of communication that Dr. Ezike is giving is very important. But without the local communication, the whole story cannot be told. It has to be both of those.
And that's wonderful, Assistant Director Tokars. And I think part of even the goal of a webinar like this, right, is to really bring to light all of the importance and the foundational aspects of rural public health systems, and things often in public health where you don't sometimes notice what goes on until something goes wrong that makes you notice it. But part of the beauty of it is that because it's in so many different areas of society, especially in rural areas where you're being called on those things, the vital nature. And so we hope that people in this webinar can also begin being communicators. I have one more question before I want to shift to the recommendations, and I'll sort of go to you, Mr. Erdman. And one of the things that we hear often as a, university and in trying to think about the right kind of partnerships with our rural communities is just the access to information. And so how do we get meaningful information to be able to know what the public health challenges are? And that specifically around COVID-19, but increasingly also pre and post-pandemic will be about cardiovascular disease and diabetes. And as somebody who has thought about those things, how do we currently think about rural public health data systems? And then, I'd love for you to shift too, but how can we think about them, moving forward to get that actionable information that really meets local needs and can also prop up the ability of local leaders to kind of make an impact?
That's another great question. I think, I hate to always focus on the negatives, but I think again, our data systems in public health also tend to be antiquated. They tend to be siloed. They tend to be antiquated. We haven't invested enough resources in our data systems. Let's take the COVID-19 crisis for an example. We didn't really have a really great contact tracing data system that existed pre-COVID. We are using Salesforce, and that's what's currently being used for that process, but it wasn't necessarily built for contact tracing. So one of the things we definitely need to improve in public health in rural areas and across the state are truly integrated data systems that are modern, that are integrated with electronic health records so that we can connect both public health and our healthcare systems. And we need to do a better job of memorandums of understanding so we can share that data across systems. If we really want to transform healthcare, we should be able to follow a patient from when they visit the public health department for something like an immunization to when they end up in the ER at a health system. More than 50% of someone's health condition is really the social determinants of health, those things that are in the environment and those things that are things that they are in need of: transportation, access to care, food insecurity. We need data systems that follow a client with those needs as well. So truly, this is such a great question. Truly, we need integrated systems that connect our public health systems, our healthcare entities, and follow a client not just through their clinical experience, but also through their holistic social determinants of health experience. There are data sets out there. We just need the resources to connect them. And that's something that we certainly need to build upon if we're going to move the public health system forward.
Thank you very much. And part of that, I think, appropriate now to shift to kind of the recommendations that this report, tried to bring to light, and things that you've heard from all of our panelists up to this point. But I think the next section of this webinar is, so how do we begin thinking about how to do that, right? So one, expand and invest in the rural public health workforce by enhancing opportunities for education and professional growth. We heard from Ms. Hammerlink about some of those challenges around having sufficient workforce, but we also know that the pandemic was a really hard time for our public health workforce. The long hours, the intensity of the work, and often in many communities not being received well for all of their efforts during an incredibly complicated and challenging time. And we know that also the pandemic led to much of that workforce also leaving public health systems. Recommendation number 2, as Mr. Erdman just said, so how do we modernize our rural public health data systems by investing in the technology and training to allow rural communities to have timely, reliable, and actionable information? This is technology, of course, how do we get the data to come through? How do we share it in ways that are legally protected, but also function in what the individual person needs, but also the ability, the training to know what that data is actually telling us, right? I think one of the things that the report sort of highlights is that where rural public health systems lack in terms of training are qualified epidemiologists. It was such a really big and important thing. And, again, how our understanding of the world changes. About a year and a half ago, most people would have had no idea what an epidemiologist is or what they do, but now often are listening to them on TV. And then the importance of public health labs was another big thing that in rural systems, just not having the ability and the training for people to know and understand the science and the real expertise that it needs around public health lab systems, and in ways that we had to run a number of tests and think about those things in unique and important ways. And finally, in thinking about Mercer County, and Mr. Rogalski and Ms. Hammerlink mentioned it, how do we incentivize the right kind of partnerships between rural healthcare providers and rural public health departments to maximize impact and avoid the duplication of resources and services? We talk about a lot in our report the idea of what a new generation of public health would look like, almost a public health 3.0. That how do we create and use the public health department really as a chief health strategist of a community? Because you heard from Ms. Hammerlink about all of the different things that a public health department does, but often communities need the right strategy, and that strategy really needs to be talked about and developed and led almost as equally by the healthcare provider in that community, because those are the places where health is talked about. And then plug in housing and plug in education and social services like WIC, because only truly then will you have the right kind of strategy. And one of the things that we could use potentially there are the community health needs assessments that hospitals need to do every 3 years, and the I-plans that are done by by public health departments to really also think about community need. And so thinking about that, and I want to kind of just take each of these kind of briefly. Mr. Urban, kind of going back to you around, public health workforce, right? And something that I know the Illinois Public Health Association sort of thinks about a lot. So we know that we don't have a lot of people, and we know that now more than ever, people know how important public health is. Could the challenges of the pandemic create the energy? And I know we've heard from some of our public health programs across the state too, that there is greater interest in public health. But how do we focus that, especially on rural communities too, where a lot of those programs tend to be at the moment in our more urban areas?
Yes, this is a great actual time, a great opportunity, and a great time to think about the future of the public health workforce because of the COVID pandemic. The Recovery Act, the COVID bills that were passed provided a lot of funding for the workforce. You heard Mercer County say that they sort of doubled their staff. A lot of those folks were contact tracers that were brought in to help with contact tracing for COVID. But I think the key question is, how do we keep those individuals invested in our public health system so that we don't just show up for COVID and then we lose them? And then when the next pandemic hits, we're at a disadvantage again. We have a labor shortage again. So this is the ideal time to think about, how do we train up that future public health workforce? One of the programs that we have here at IPHA is we received, thanks to IDPH, we received some significant funding to develop a community health worker pandemic health navigator program. It's our COVID PHN program. Through that program, we've been able to train 500 community health workers on all kinds of really foundational skills in public health, not just COVID, although that was the funding that really sort of started that, but really we're training them in the foundations of public health so that they can be trained to enter the workforce and stay in the public health workforce, particularly in rural areas where there is a shortage of public health workers, so that these individuals can be housed at public health departments, at clinics, at health systems. And then when the next pandemic rolls around, we will have them with the skills necessary to face those challenges. So this is the ideal time, I think, with the resources that we currently have, to hire staff, to train them up, to give them the foundations in public health, and to keep them deployed in the public health system so that we can address these future challenges.
Wonderful. Thanks so much. I think really sort of an important time, right? And an ability to kind of make an impact. Just a reminder for those in the audience, if you do have a question, we'd love to begin sort of thinking about those. You can add them to the question and answer box. As we wait on that, Mr. Rogalski and Ms. Hammerlink, I sort of mentioned those community health needs assessments, and those I plans. And I know Mercer County, even before the pandemic, has sort of thought about and the importance of that partnership. Would you be able to kind of describe the audience, how that came together and why it was thought that this would be a really good thing to kind of partner on together to create a community health strategy? Mr. Rogalski, I'd just love to start with you.
Thanks, Samir. And yes, you're absolutely right. And as you and I have had these conversations over the last couple of years, I've been beating on that drum, right? How can our rural communities collaborate better together? And to me, it's merging those two community health needs assessment I plans together, because there are a lot of communities that aren't like us. As I talk to colleagues across the state, we're a little unique. We've been collaborating on our community health needs assessment I plans for the last 10 years since I got down here, and we've divvied up, those challenges that we face in our community. So, the health department can really kind of focus on those social determinant issues. We can focus more on the provider clinical side. And I want to give a really great example on how we leverage that work. Ever since we started our assessments, behavioral health had been a huge gap in our community. And so that was really a focused effort. As a provider, we got the resources on board with a licensed clinical social worker and a nurse, behavioral health nurse practitioner. So at least we could start providing that in the community. And it allowed us to apply for a federal grant and bring in over $700,000 into Mercer County over a 3-year period of time to really enhance our community mental health services. So the key component of that from the health department side was a nurse navigator, and Jen was the key link on that. So I'll kind of turn it over to her to expound on that.
Yeah, it's one of our favorite programs. By partnering with the hospital and applying jointly, which is one of the key strategies of Public Health 3.0, is to look for collaborative funding opportunities. And by doing that, we were able to leverage each agency to be able to meet the needs of behavioral health in our community. And it's went really well. We've far exceeded every goal that was ever set for that. We are currently fully sustainable for 3 more years. We just embrace that. And along with that, I'm sure Ted would agree, through our community health needs assessments and planning, we have all really adopted these as living documents. And, sometimes they just sit on the shelf, but we decided that we were going to look for hands-on service opportunities for our residents. So we were going to quit, just planning at the 20,000 foot view, and we were going to find out what really needed to be done. And those strategies were so beneficial during COVID, because if we needed to have a vaccine clinic and share staffing, we just did it. We just made it happen. If people couldn't get to the clinic, we went and got them. We looked for housing and rental opportunities for people. We have kind of adopted this navigation type model throughout both of our organizations now, and it has to sustain. And what Mr. Erdman said is so true. Now that we have people trained up, we have to be able to continue to fund them to stay in the workforce, because no matter how skilled and wonderful they are, if we don't have funding, they're gone. So we are constantly looking to do that, but only for writing for grants that we actually need to do. We don't want to fall down that hole where you just write for a grant for money. We need to write for grants that improve our community and employ people to do good work.
And back to you, Assistant Director Tokars, and sort of hearing, some of these examples. And I think one of the things that I just want to highlight from the State Department of Public Health is just the new work being put into the State Health Improvement Plan, and having the sort of honor and privilege to be part of some of those discussions. That the State Health Improvement Plan, the focus, has typically been around disease entities. But a lot of the focus and conversations that are happening now around designing the State Health Improvement Plan is really around public health infrastructure. And by that, a lot of the things that we're talking about now, workforce, data, how do we build those things so our public health system infrastructure is robust? And would love for you to sort of discuss a little bit about the State Health Improvement Planning process, and how and why the public health department has thought to make this kind of really important shift.
Thank you, Dr. Roja. First of all, what I hear my colleagues saying is so important for people to hear from what Jeffrey's talking about with workforce and Jennifer and Ted talking about these exemplar partnerships, unselfish partnerships. And one thing that used to happen before the pandemic, sometimes when people said partnership, sometimes it was really code for what could I get from you? But what you hear now is what can we do to help each other? And this is the kind of partnership that was always intended. So let me go ahead and say something about the State Health Improvement Plan. The state, with our local health departments, all local health departments by law, as part of being key health strategists, that's really is that they are assessing with their partners what's happening on the ground here, and what are a few things that we can do together. So the state's doing the same thing. Traditionally, the state has been most influenced by big data in the State Health Improvement Plan. But Dr. Roja, you participated, and we had individuals from all over that state participating. And something that I felt was very important is that we be influenced by what locals were doing in their health improvement plans. That matters a lot. Small data matters. And so here is what we are focused on now, not dissimilar from what many local health departments are doing. The priorities are behavioral health, chronic disease, maternal and child, social determinants of health, with a great emphasis on all of these areas on health equity. Now, we are not really funded for behavioral health. Okay, that's DHS. Most, maternal child health funding is also in DHS. So we, like local health departments, we're not looking at what we're funding for. We're looking at what can we partner about and talk about. So those are, I hope I answered your question. You might have had more to your question, Dr. Roja, but those are our goals.
Yeah, no, it's wonderful. And I think we're in this group and for the audience to know that important direction on kind of the state health improvement plan. I want to take these kind of two audience questions now, and they're very, I think, perfectly set up for us to use the last 8 minutes to kind of conclude the webinar. One of the biggest, and it's still, although we've moved at a very important pace, but now as the Delta variant sort of continues and cases are rising, across the country, Dr. Odin asked, what ideas do you have to motivate the hard-to-reach population in rural areas to make the decision to get themselves and their children vaccinated? And Ms. Hammerlink, I'd love to start with you, and then would love to get any other kind of comments from the panelists.
I mean, certainly that's something that we're all facing. We just continue to send that message out. And I think one of the greatest things our administrator identified recently was you're talking about people not understanding what public health departments do. There was a lot of talk about quarantine and isolation and a lot of anger from the community until we started saying, this is no different than we respond to other disease outbreaks. We didn't make this up for COVID. So it's a great strategy with vaccine too. This isn't just a COVID vaccine, this is a vaccine. We do vaccines all the time. Vaccinations are proved to be safe. Vaccinations help the whole community. Don't you vaccinate your children before they go to school? Well, yes. People have such a kind of a misconception that this is a dangerous vaccine that we're trying to bring it back to normal a little more for them. Other than that, we do as media, and we just talk about it a lot. We train our staff to be representatives in the community. We have, this is one of, I think, Mr. Rogalski's ideas. We have local leaders, and Ted, you could speak to this. We have local leaders going on and doing videos on social media. Do you want to speak to that, Ted?
Yeah, we're just trying to chase down all avenues to try to get the word out. Most of the data I have seen is that healthcare providers are the #1 trusted resource, right? So getting our physicians and our advanced practitioners out there talking about this publicly, that it is okay. But two, it's also a partnership with the school districts, right?
Yes.
What incentives can we put in place? And maybe some of that's a little bit of a stick in that, hey, your child's going to have to go home with any illness for a 14-day quarantine period unless they're vaccinated, right? So that's an incentive that we would love all of our school districts to adopt to hopefully promote higher vaccination rates. Right now, we're sitting at 25% going into the school year start, and that's certainly not high enough.
Yeah, wonderful. And as a pediatrician too, right? And I think to Ms. Hammerling's point, right? Vaccinations are something that we're constantly talking about. We know the effectiveness, and especially we've seen the effectiveness of this COVID-19 vaccination, and it's hard and often also to be vulnerable enough to really listen to what people are concerned about, right? And I think one of the challenges often comes decision links to judgment, but without sort of opening up the vulnerability to listen, right? That all of us can be messengers can be, I think, also really important. And the terminology that's used. And I think there's been some really good data by some national groups around, often in different communities, different cultures, words and the words that you choose to describe a vaccine are also very important. And so my last question to all of you, and maybe I'll ask for it in a brief way, from Caitlin Frick, and I think the biggest and most important question of a webinar like this: how do we take policy recommendations and plans and put them to action, especially at a time of limited resources? And so maybe if we can ask everybody to kind of give it a little bit of a couple lines and descriptions on that, we'll perfect sort of conclusion comments for this webinar. Assistant Director Tokars, can I start with you?
All your questions are worth a whole seminar. That's such a big question. So maybe I'll say two ways. So on the matter of formal policy, you know, for health departments and health partners and hospitals, and even physicians' offices and pharmacies that have policies that they want to put in place around the way that they approach, it's really important that the way that they talk about that policy is as best as possible translated that way on the ground in the way that people receive it. So if your policy, let's say your mission statement is a policy that we want to be the best place that people come to, then, and that they trust, then what are all the ways that people gain and lose trust when they make that phone call at the receptionist's desk, when they try to follow, you know, all those things. So health policy that builds trust is the most important kind of policy. But I also want to talk about the polity of policy, because the polity is the way that it plays out. And if we are not noticing the polity of that, meaning the way that people experience that, we will not be able to be astute strategists. So in terms of vaccinating people, you know, all communities are different. Sometimes it's better to go to the places where people already are and offer vaccination. But in some places, the ideology is so abhorrent to the idea of vaccination that it's better to approach people individually and let them go to their physician's office, or let them make appointments where they can talk one-on-one about their concerns for their family. So we have to pay attention to the way people experience our policy, and we have to pay attention to what happens to policy once it goes forth and the polity of that on the ground, and being sensitive to that as well.
You know, that's wonderful, Assistant Director Tokars, and unfortunately we're right at the end of time, but I think that's an incredible message for everybody and everybody in the audience about how affecting these policy recommendations can be based on all the things you learned today, examples of the things of the people on this panel and the wonderful work that they're doing, and the wonderful work that all of you are doing in all of your communities. As Ted put it, we all started and took on the pandemic without having all the answers, but have shown great resilience and work in all of our communities to make an impact. So again, I'm Samir Vora, and on behalf of our Rural Health Summit partners, thank you all for joining us for this COVID-19 and Rural Public Health Systems webinar. We'll join you, and we'll hopefully see many of you next coming up on August 19th, 2021, where we take on our next topic and the importance of COVID-19 and its effect on rural nutrition and fitness. And so we look forward to having you join us then for another incredible panel and another really engaging discussion. Thank you, Dr. Tokars, Mr. Erdman, Mr. Rogalski, and Ms. Hammerling for this incredible conversation. And thank you for all the continued great work and service that you're doing in the communities and across the state of Illinois.
Thank you.
Thank you.
Thank you. Have a good day.